Sorry. Is everyone seeing the presenter mode or the regular mode?
You have to switch it.
Oh, okay.
Yep, that's right.
Okay, cool. All right. Good morning, everyone. My name is Ray, and I'm currently on the spine service, and I'll be giving the spine conference for today. So just to start off with a clinical presentation. So this is actually a pretty recent patient that we saw through the ED. She's a 22-year-old. She woke up one day with really severe neck and right shoulder pain, and the pain is going to her right upper extremities. And she tried Tylenol, she tried gabapentin, and she went to a different outside hospital ED. They also gave her opioids, but the pain only got in short relief and then immediately came back. And by the time we saw her, she was crying in pain. And the exam is also listed on the slide. And we eventually got an MRI for her, which demonstrated these findings. So just to give the junior residents some practice in describing imaging, Dan, can you give a quick description of what you see on her MRI?
So I see it looks like on the sagittal, I think that's C2, 3, 4, maybe C4, 5. Paracentral disc herniation affecting the right side with pretty severe stenosis. I don't see any cord signal change, but yeah, pretty severe stenosis.
Okay,
infecting, it correlates with the weakness, yeah.
Okay, good. Yes, it definitely correlates while her symptom was the foraminal stenosis definitely causing severe compression of that nerve. Ainsley, when you see her and also see this imaging, what additional symptoms do you want to ask about? Because she's in a lot of pain. She might not tell you outright that she has other things going on, but you, as a person taking this consult, should definitely check.
I would want to ask specifically about like myelopathy symptoms, so like hand grip and trouble, if she's had trouble with buttons, and then try to investigate if there was any trauma. It's weird that it happened all of a sudden when she was waking up, so want to get better history.
Yeah, that's a great point. Myelopathic symptoms is definitely important in this case, and including the fine motor issues. You also want to check how's her gait. Does she have gait issues, balance issues, and also the routine question that we ask about bowel, bladder. All of that is important and can be part of the symptoms for these patients. And Chi, what addition? You saw the MRI. What other imaging we can obtain, and how will they be helpful?
So I would also want to get a CT as well at the cervical spine. I think it can help with surgical planning. I think looking at the, I'm sure you're going to go on later on to discuss like the surgical options. So I think looking at this, if we were looking at the anterior approach, then we can also take a look at a CT to help us with deciding.
Okay, good. Yeah, CT. And more specifically, CT will help us look at the bony structure better and be able to tell if a patient has OPLL. Although we started off with this patient being 22, it's unlikely she has that. But again, a lot of times we're seeing older patients with this kind of presentation, so it's important to consider. And also upright x-rays, right? So this, we should always remember when we're getting MRI, when we're getting CTs, these patients are there in the lying down position. So that might not be the alignment that you see when they're actually upright. So their spine alignment can look perfect when they're lying down, but when they're standing up and actually like weight bearing, it can look completely different, and also that's going to affect how you plan out their surgical procedure. Okay, so not gonna delay any further, but when we are considering her surgical options, the two main ones that we talked about is anterior cervical discectomy fusion, ACDF, and also cervical disc replacement. So I think everybody has seen these procedures done at our institution. But the topic on discussion for today's whole conference is that how do we choose the which procedure to use, and also the difference in outcomes between these two. So who else is on the line? Matt, do you want to comment on from what you've seen? What are the considerations that we tend to look into in deciding between these two procedures?
Yeah, so I think one of the main things, or sort of the main thing, is whether the patient needs a fusion. If they have a lot of neck pain as a significant portion of their complaint, then the disc replacement might not help that, as a fusion might. And then alignment, you could sort of restore or improve some alignment with the fusion, which you can't necessarily do as well without disc replacement, or that might be a reason to do a fusion if she has this poor kyphosis. That's where I think the upright X-ray would be pretty useful. And also her age, obviously if you could spare, do like a motion sparing surgery in a 22-year-old, like favorable.
Okay, yeah, exactly. Those are all factors that we talked about during our spine conference, and where we're deciding on the exact procedure for her. We definitely talked about her age. Her being really young is preserving the motion for that joint is probably beneficial, since the theory is that if we preserve the motion, then there might be a decreased chance of adjacent segment disease. Since with a fusion, the force of the motion is more concentrated at the segments that are right near the fusion. And also alignment deformity, as Matt already talked about. If she has a significant deformity on the standing X-ray, or then we would consider correcting that. And the cervical discectomy and fusion would be a better choice for actual deformity correction. And also another consideration is that if we have a older patient with a lot of osteophyte in that region, and even in order to get into the disc space, we need to do a lot of drilling down the osteophyte, then arthroplasty might not work, since all that bone work is going to promote fusion. And lastly, surgeon comfort is also a variant, since arthroplasty is still relatively new, whereas ACDF has been around a long time, and pretty much all neurosurgeons are very comfortable with this procedure. So cervical arthroplasty, like we already talked about, is a motion preserving procedure. And the theory is that by preserving the motion in that segment, it mitigates the risk for adjacent segment disease, since the stress of motion is more evenly distributed, like the original biomechanics of the cervical spine. And also there has been a comparable safety and the performance outcomes at the mid and long-term follow-up compared to ACDF. Since the first cervical disc replacement device was originally FDA approved in 2007, and there's really a boom of these clinical trial and all different kinds of devices coming out in the early 2000 and teens. Currently, there's a decent amount of studies out there with midterm follow-up, like 5-year follow-up data. So what are the recent updates on this procedure? There's a couple of interesting papers I found that I'm sharing with everybody in this conference. The first one is a big database study. this is a pretty recent paper published in World Neurosurgery looking at the single level disc replacement versus the ACDF, and it's using a nationwide data set and also looking at outcomes that includes immediate complication, 30-day and 90-day readmission rates. So it's a pretty large data set. Approximately 13,000 patients in that data set underwent ACDF, and almost 2,000 patients underwent disc replacement. The overall trend is still that more ACDFs were done, and these were done in patients that are older and also with higher comorbidity burden. And the disc replacements tend to be performed on younger patients. Again, that goes back to our point where we're considering disc replacement more commonly in younger patients, because knowing that they will live with this device for a long time, and the longer time we can try to mitigate adjacent segment disease, the better it is. And also this study was done with propensity score matching. And they, in the result, they affirmed that the disc replacement was non-inferior. But looking at some of the more detailed results, this table demonstrates the intraoperative and postoperative complications of CDR versus ACDF. So there was some trends of the CDR group having slightly lower rates of complication, but that was before the matching. After the match, propensity score matching, you can see that pretty much they have similar rates of immediate intraoperative and postoperative complications, which is understandable since both procedures pretty much have the exact same approach and surgical steps. And also in terms of outcomes, it's kind of interesting that the disc replacement patients had higher cost of inpatient stay compared to the ACDF patients, and that remained true even after the match. However, they actually had a shorter length of stay compared to the ACDF patients, about a day shorter, and that was statistically significant even after the match. So this is not just from the comorbidity and having a younger patient age population, but overall it's reassuring that this procedure it have a similar safety and complication profile as ACDF. But that's a large national cohort study, so there's a lot of downsides to that, to those kind of studies where we don't really get the more granular details of the patient and the procedure. So this is another study that's recently published. It's actually published in a spine journal, and it's a long-term look at a clinical trial of the M6 cervical disc device. And I also found this device to be really interesting that I wanted to point out. It's designed to be a very close approximation of the natural cervical disc, which they designed to have like a layer around the outside that emulates the annulus, and in the core they have a polycarbonate polymer. So they really try to replicate the biomechanical structure of the native disc, and the design also allows it to have 6 degrees of freedom. So this is the patient cohort they had about 173 patients that underwent this device implant, and at the same time they had 85 patients that underwent an ACDF. But to match up the numbers in terms of the cohort, they later retrospectively added another almost 200 patients that were treated with ACDF, and they looked at the primary endpoint, which is the clinical outcomes of these patients at 24 months, as well as 6 months, which is the 5-year mark. So looking at the neck pain score and also the arm pain score, at baseline, both of these groups experienced significant improvement in symptoms, both in terms of neck pain as well as in terms of arm pain. The authors did find that the subjects who treated with a disc replacement actually had better outcomes in terms of NDI score than the ACDF group, both at the most significantly at the 60-month follow-up. And then also in terms of radiographic outcomes, the disc replacement group had preserved motion as expected on flexion and extension, and also lateral bending. So as expected, the ACDF group, most of them achieved the fusion, so there was no preservation of motion. And they also found that the disc replacement group had a slightly lower rate of revision for adjacent segment disease, because at the 6-year mark, only 2 out of 113 patients who followed up required fusion on the adjacent segment, as compared to the ACDF group, which had 7 out of 106 patients who underwent a further fusion procedure for adjacent segment disease. Okay. And what about multi-level constructs? So, well, as we all seen, like a lot of patients have multi-level disease, and we commonly do multi-level ACDF, and those have been shown to have good outcomes. But what about a multi-level disc replacements? So this is a paper that's recently published in JNS Spine, which looked at 3-level disc replacements. So they had a decent sized group of cohort, 50 patients, and they compared these patients who had replacements at C3 to 7 with another 50 patients who underwent ACDF at the exact same level. And also this study was pretty well matched in terms of patient comorbidities and age and sex. They found that at the 2-year follow-up, the clinical outcomes were quite similar. Both groups had very significant improvements in terms of neck pain as well as arm pain. And the disc replacements did preserve the mobility at the levels that were operated on. So the mean range of motion at those levels were 3.4 degrees, where compared to the ACDF group, they only had less than 1 degree. However, they did not comment on the rates of adjacent segment disease. In addition, they did found that, again, 2 groups had a very similar immediate operative complication and post-operative complication rate, and as well as operative time and estimated blood loss. So what about hybrid constructs? So there's fairly few studies out there really looking at hybrid construct where you use a combination of disc replacements as well as discectomy and fusion. The few studies out there also only had very low patient numbers. They were mostly around the teens, and 20. The largest group had maybe 20 to 30 patients. But again, in terms of outcomes, short-term outcomes, the hybrid structures were found to be non-inferior to both ACDF and disc replacements, and the hybrid construct were found to have better preservation of range of motion and less compensatory range of motion in the adjacent segments. And there was no significant difference in adjacent segment disease in between the three groups. However, the caveat is that these studies are all have a fairly short follow-up term. Most of them were only in the range of a couple of months, and again, not enough patient numbers to really give us the same comparative data as some of the other single level or single constructs studies have shown. So in summary, there's been an increase in overall utilization of cervical disc replacement as surgeons become more comfortable with this relatively newer device. More and more surgeons are starting to use it, and using it in older patients with higher comorbidities as well. Currently, there's a pretty large body of evidence that shows that it's non-inferior to the traditional ACDF, and also that these devices do preserve motion as their intended design. There's some studies out there that suggest that they have a reduced rate of adjacent segment disease, but again, more right now we're kind of just reaching like the 5-10 year mark for these devices. So there's still more studies coming out with these long-term follow-up data. And also we definitely need more clinical evidence as well as longer term follow-up time to understand the outcomes of multi-level arthroplasties and also hybrid construct. And also we also need more evidence on the different levels where these devices are put in, and see if there's a difference between replacement at a higher level versus a lower level in the cervical spine. So I just want to end off by saying thank you to all the spine attendings. Despite me not matching the greatness of our recent graduates, such as Dr. Ladner and Dr. Yuck, all the spine attendings have been incredibly supportive, and I really learned a lot during my short 1.5 months on the service, and I look forward to continuing and really progressing with my spine training.
Great, thank you so much. Thank you for your great presentation and your great work over the last couple months, and certainly you've done an amazing job. I will say that this topic is a huge one and an important one. This particular patient, which is my patient, we ended up choosing to do the ACDF fusion on. There are many factors that go into it. You covered almost all the important ones, but the one thing that was undercovered is the myelopathy question. And this patient did have hyperreflexia, had a right-sided Hoffman's, and had right proximal leg weakness. And the weakness was not just in the C5 nerve. As you pointed out, it was even worse. And when I saw her, she was about 3- on the deltoids. And although there were 2 days of acute deterioration with weakness, certainly she had a history of many months and even years of right-sided arm symptoms, shoulder, which was unclear if it's related to this. At surgery, the disc was very stuck to the nerve on that right side. It's Alejandro who had to cover it because of the interviews and you were busy. So ultimately, I think that the data is still evolving. Many of us established surgeons probably underuse arthroplasty. However, I think with myelopathy, it's still a fair question, and a number of people have shown it's acceptable, but others believe it's not ideal. And I think that the main issue is the adjacent segment disease. As you pointed out, some studies are showing some advantage, including that study that showed a pretty significant advantage. On the other hand, other studies have not shown an advantage, and there is a rate of higher same segment disease with posterior heterotopic ossification and other things in the facet, arthropathy, and so forth. But I think it's an important topic. The data is still evolving. We have to monitor it periodically in our conferences, and thank you again for your presentation.
I have a couple of comments, since this is an area of particular interest in my practice. The first thing to say about cervical disc arthroplasty is to recognize that we have amazing data in this particular area. There are multiple prospective randomized studies that look at cervical disc arthroplasty. What area in neurosurgery can you say that we have prospective randomized studies? Most of the studies have shown clinical equivalence to fusion, or at least they were looking to show non-inferiority. One of the things that does come out pretty consistently through large series is that the reoperation rate, not necessarily for adjacent segment degeneration, but just looking at who had additional surgery, it's consistently lower in the disc arthroplasty group. Maybe some of that is because of pseudoarthrosis and the same level needing surgery again in ACDF, or loss of plate fixation, or whatever reason. And even though the difference in any given study tends to be small, it does seem to be a thread that passes through study to study. And I wanted to comment on one other point that Dr. Chowdhury brought up, which is very pertinent. The initial intent behind the arthroplasty procedure was to treat radiculopathy, and no one, I think, initially was thinking that you would treat spinal cord compression or people with cord signal change. The idea was maybe that the cord is beaten up and it needs to rest, and therefore you should fuse and shouldn't choose a motion preserving technology. And that idea never really was borne out in any particular study. And recent data has actually shown that disc arthroplasty, if the anatomy is right, is a suitable operation. And I want to give credit to Alex Schupper. He and I published an article in this month's journal, Clinical Spine Surgery, which showed that disc arthroplasty is a suitable alternative to ACDF for cervical myelopathy. So good work, Alex.
I'll just comment that I've been doing more disc replacement hybrids with ACDF. I think it's a really good option for someone who has a nice looking healthy disc, but with cord compression or severe foraminal stenosis, but degenerative discs below. Just because you think about going from a 1-level ACDF with really high fusion rate and low dysphagia rate, and then you go up to a 3-level ACDF, and all of a sudden you're talking a really high, 20% at least pseudo rate and more dysphagia in the short and long term. So I do think that it just that's been something that I've been working on. I think it's probably we have enough now to start thinking about doing some sort of study. So I think I would throw out that I'm interested in doing that. And also I would just tell the residents, a lot of patients now are very informed about options that are on the table, and some people will come in saying, I want a disc replacement. I think it's very important to stick to your indications as the surgeon. And I've told plenty of patients, all else equal, I prefer disc replacements to fusion for the right indication and the right patient. But I don't want to be flexible on indications due to patient requests. So just a reminder to stick to what you do best and resist molding your plan to a patient preference.
Something else interesting about the question of whether motion preservation will retard the development of adjacent segment degeneration. We don't have excellent proof for this concept, but a lot of people who do a lot of disc replacements have a sense that the data from the studies that started 10 years ago or more were all studies of single level disc replacement, and perhaps the single level disc replacement is not such a marked effect that you can show statistically well that the adjacent segment is being protected. But now that we're doing multi-level, it could be that multi-level is going to have a more magnified effect in protecting the adjacent segment. And those studies are ones that we're anxiously waiting to come out.
Two final points. One is this patient has a dancer and is generally speaking hyperflexible, hypermobile, and I think you have to factor that thing into it. Not sure how you factor that in, but certainly you have to think about that. And second, final point is, I think you correctly pointed out, Dr. Hooten, that there's a lot of randomized studies in this thing, but the reason why that happens is because many of them are very heavily industry sponsored and for their particular device. So I think that there's certainly a little skepticism on some people's part on some of the data. But yes, this is an important topic and we'll continue to talk about it.
That's a good point. Just one final thought on this loss of motion and a person being a dancer. I get asked all the time by patients when I recommend a one-level ACDF, doctor, is my neck going to be stiff? Am I not going to be able to move? So, I tell them that a one-level ACDF, even a two-level, it's going to be hard for most people to be able to even notice or discern any change in their range of motion. Unless someone is a world-famous gymnast, they probably are not going to have any functional change with a one or two-level ACDF.
Just one more comment. I don't know if this has already been covered, but in terms of the material science, we don't know what is the long-term outcome of these devices, that they're subject to millions of cycles of loading in the human body. I mean, definitely they're getting tested in the lab where they're being subjected to million cycles and they seem to be performing well. But inside the human body, we don't know how they perform because there are some differences compared with the lab and the human body. Most likely they will be fine, but I just want to bring that up because we have seen, for example, with joint replacements in hips or that there were some issues that came up after years of using the devices. So that's a low concern right now, but we should notice that. Well, we know with the ACDF, once that area fuses, then we don't have to worry about that level ever again.
Great point. The hip and knee literature is after 20 years, it can be a problem. We don't have that for the cervical arthroplasty lash, so more to come.
Thank you all. Great discussion and great comments from everyone. Ending a little bit early today, and we'll see you all next week in Hatch for the Holland lecture.
Thank you.
Love to help you. On a hybrid study period. I've done quite a few as well, but I don't think that I'm going to be able to capture that data from my prior institutions.